Did you know that on average over 50 Malaysians die of heart disease every single day? This makes it one of the leading causes of death in Malaysia. Heart attacks can happen anywhere, anytime. And when they do, immediate healthcare is critical. Take this guy for instance.
Sir, are you okay?
Let me just spin.
Hang on, I'll help you.
Kamu panggil siapa?
Emergency services.
Cuba kamu panggil ni.
Hello?
Glen Eagles has their own dedicated emergency line that you can call 24 hours a day. Wow, that was quick. Mestilah, because when a person has a heart attack, appropriate action must be taken within the first 60 minutes. This is often referred to as the golden hour. So, doctor, tell us, why is the golden hour so important?
Well, a heart attack is a medical emergency. The longer it goes on for, the more damage is happening to his heart. And the sooner that we can restore the blood flow, the higher the chances of survival.
So it's a really good thing we got him in quick.
Yeah, he's lucky that he came in early. And if there's no complications, then he should do quite well. So let's go.
Well, doctor, we're now in the cardiovascular lab. So what happens now?
Well, we've brought the patient up to the cardiovascular lab. The heart attack is caused by a blockage in the artery on the front of his heart. The cardiologist has managed to put a wire through the blocked artery. He's put a balloon down. He's managed to remove the blockage. There's still a very severe narrowing, and he's now fixed that by putting in a stent. And now that the flow to the blocked artery has returned back to normal, the heart attack has been treated, and we are now going to put the patient into intensive care unit.
Great.
How are you? Better? Any more chest pain?
No more chest pain.
It's good that you come on time, but you had a massive heart attack. Everything went well, so we just need to monitor you for a couple more days before you can go.
Thank you, doctor. With 2 full-time experienced interventional cardiologists backed by a competent clinical team, the 24-hour heart attack facility at Glen Eagles Hospital, Kota Kinabalu, is best equipped to help you and your family members in the time of a heart attack. For any inquiries, call now on 088 51 8888. It's 088 51 8888.
Good evening, everyone. Thank you for joining our online CME Live today from Glen Eagles Hospital, Kota Kinabalu. My name is Lucy, and today we have Dr. Ahmad Ashraf, our resident interventional cardiologist and physician, to share with us on stable versus unstable coronary artery disease. Before we start, allow me to brief you a little of Dr. Ashraf's background. Dr. Ashraf completed his undergraduate medical training at the Royal College of Surgeons, Ireland in 2000. After 5 years of internal medicine training, he began his specialist training in clinical cardiology in year 2005. In 2007, Dr. Ashraf joined the Mater Misericordia University Hospital Dublin as a clinical and interventional cardiology specialist. The Mater Hospital is the National Heart and Lung Centre for Ireland and is the tertiary referral centre for advanced, complicated and end-stage cardiac disease. In 2010, Dr. Ashraf was appointed as the first ever interventional fellow in cardiology at the Mater Hospital. He spent the next 3 years training in advanced interventional cardiology. His specialty is in primary angioplasty and complex coronary anatomy, including chronic occlusion of coronary arteries. He performs the majority of his cases through the radial artery of the wrist, which allows patient to mobilize earlier and reduces the risk of major bleeding complication. If you have anything to ask Dr. Ashraf, please send it to the comment section and Dr. Ashraf will try to answer your questions towards the end of our session. Without further ado, I will pass this session now to Dr. Ashraf. Good evening, Dr. Ashraf.
Good evening, Lucy, and good evening to everybody who's online watching this. So the topic for today is stable coronary artery disease versus unstable coronary artery disease or acute coronary syndrome. So it's been interesting 2 years. Most of it has been taken up by COVID, of course, and just some pictures of how things have been progressing over the last year. And of course, we get regular updates on COVID and how many people have had it. I showed this because it's taken up almost all of our attention in the medical arena. Everything is almost the only thing that we talk about, whereas we should also keep in mind all the other medical problems that people can suffer. This is the most recent data from America, which showed that last year in 2020 there was a 17.7% increase in the annual deaths from all causes in America, almost all of which is driven by coronavirus. So you can see that the death rate went up by almost 500,000 in America alone. So that sounds like a big number, right? 500,000 deaths from coronavirus. Yet, when you look at top 10 causes of death, it turns out that in America, heart disease still remains the number one leading cause of death, accounting for 690,882 deaths, and coronavirus accounted for 345. This is of course last year, and this year there's been even more deaths from coronavirus, and soon coronavirus will be the most deadly pandemic that's ever affected America. It will overtake the 1918 Spanish flu. The situation is the same in Malaysia. Even though coronavirus takes up our imagination, our attention, the main cause of death in Malaysia remains coronary artery disease, and in 2018 it accounted for 18,000 deaths. I tried to update this, but unfortunately I couldn't get any more recent data available that I could find. But the numbers will remain the same and probably have continued to grow in 2020 and in 2021. And the 5 main causes of death in Malaysia, number 1 is coronary artery disease, number 2 is pneumonia, and so on. And on average in Malaysia, about 50 people will die every day as a result of coronary artery disease. So it is a leading problem. The main risk factors for this is, apart from age and being a man, would be having high blood pressure, high cholesterol, having diabetes, and smoking. In Malaysia, 94% of patients with heart attack will be older than 40. 83% are men. About 70% will have high blood pressure, 55% will have high cholesterol, 45% will have diabetes, and 49% will be smokers or ex-smokers. When you have these risk factors, and as you get older, what happens is that there's repeated injury to the blood vessel, which the body responds to the repeated injury by covering the areas of injury with cholesterol, which results in these early fatty deposits within the lining of the blood vessel. Now, repeated injury happens at the same place, which leads to excessive buildup of cholesterol in the same location, and eventually this leads to a significant stenosis. Okay, so this is the natural evolution of coronary artery disease. And with this natural evolution, what happens is that as the lumen gets smaller and smaller, there'll be less and less blood that's able to get to the affected area. So when the heart requires more energy than it can get, then the heart muscle starts to hurt. And this is what we call angina. This is coronary ischemia from inadequate supply-demand mismatch. Okay, this is what stable coronary artery disease is. There is still a blood supply getting to the affected parts of the heart, but when the heart is stressed, it's inadequate, causing symptoms. So the symptoms of stable coronary disease are chest pain or chest discomfort, pain either in the arm, the neck, the jaw, the shoulder, or in the back, nausea with exertion, reduced effort tolerance, easily fatigued, shortness of breath, excessive sweating with mild exertion, dizziness. Okay, and it's important that in stable coronary disease, these symptoms only occur with exertion, or as a result of these symptoms, they limit the person's effort capacity. Okay, and the symptoms are self-limiting. That means when you stop the activity that's causing the symptoms, they disappear, they get better. Or when you rest, or if you take medication such as sublingual TTN. Typically when you have symptoms, you can get ECG changes, sometimes you don't, and again these ECG changes should disappear when you stop the activity or you rest. And cardiac biomarkers, the troponin T, the creatinine kinase will be normal. So these are all the hallmarks of stable coronary artery disease. In unstable coronary artery disease, there's been a sudden disruption in the supply of blood. Usually what happens is that one of the cholesterol plaques that's inside the coronary artery has become damaged and the surface has broken open. And the contents of these coronary plaques is cholesterol-rich lipid. And when this comes out and it comes in contact with blood, it causes an almost instant reaction with the blood, causing the platelets to clump together and activating the coagulation cascade, causing a clot to form where the cholesterol has leaked out. Okay, this clot will quickly block off the blood supply of the heart, so now there's no blood supply going down, and this will lead to a heart attack. Okay, now this picture that I showed is a nice static picture. It shows everything in sequence, but that's not how the clot behaves. It's a constant dynamic process. There's factors in the blood that's causing the clot to get smaller. There's factors in the blood that's causing the clot to get bigger. So if you have more of the factors that cause the clot to get bigger, then the heart attack will progress fast. If you have more of the factors that cause the clot to get smaller, then you can actually reverse this so that it doesn't become a complete heart attack. It becomes a small heart attack, a non-ST elevation MI. So that is the spectrum of unstable coronary artery disease or acute coronary syndrome. It ranges from small heart attacks to full-blown complete heart attacks. But there will always be some damage that's happened to the muscle of the heart, the myocardium. What are the symptoms of unstable coronary disease? Surprisingly, it's the same symptoms as stable coronary disease, but the change is in the severity and the onset of the symptoms. So the symptoms happen with increasing frequency. The symptoms now start to happen when you're not doing anything, you're just sitting at rest, you're having chest discomfort or arm discomfort or shortness of breath, and it can happen unprovoked. Importantly, when it's unstable, these symptoms will not resolve with rest, will not resolve with taking medication, and typically if it lasts longer than 5 minutes, that's a bad sign. The ECG changes do not resolve with rest or with medication, and frequently when you do the blood test, the troponin T will be elevated, the other cardiac biomarkers will also be elevated. So this is how you can tell what is stable coronary disease versus unstable coronary disease. Stable coronary disease only happens when provoked by activity and is relieved by rest. Unstable coronary disease will happen unprovoked at any time and will not be relieved either by rest or with medication. So let's give an example of an unstable acute coronary syndrome. This is a 58-year-old man. He has no past medical history and he doesn't smoke. So his risk factors is he's a man, he's over 40. He's had chest pain since 5 in the morning, and after 3.5 hours it became very severe. He decided to come to the hospital at 9 in the morning. And when he arrived, his blood pressure is very high, it's 199 over 115. So he probably has high blood pressure which is undiagnosed. So now he's got 3 risk factors. So we do an ECG, and in this ECG, you can look in the leads 2, 3 and AVF here that there's ST elevation in this segment here. So this is ST elevation myocardial infarction in leads 2, 3 and AVF. Now these leads, we call them the inferior leads. So when you have ST elevation in the inferior leads, you have an inferior ST elevation myocardial infarction. And this is usually due to a blockage of the right coronary artery. So the initial treatment is we want to give blood thinners. We want to try and block that coagulation cascade. So we give aspirin. Nowadays we have stronger medications than aspirin, which are also antiplatelets. They block a slightly different pathway, and these are called thienopyridines. The commonest one that we use is clopidogrel, Cogrel, Plavix, but in this case we use an even stronger one called Brilinta. We also give a cholesterol medicine, and the reason we give a cholesterol medicine this early on is because there's evidence that giving it early on helps to stabilize the plaque that has ruptured, prevents that from happening more easily, and may help to prevent further heart attacks from happening. We can also give additional blood thinners. Sometimes we give heparin intravenously. That also helps to limit the clot from enlarging. And the best treatment for this sort of unstable coronary disease is to do emergency angioplasty. So we take him to our cath lab, and we do an angiogram. So the picture you're looking at now on the left hand side, that's the artery of the person who just came to the hospital. This is his right coronary artery. On the left, I just gave an example of what the normal right coronary artery should look like. So you can see when you compare the two that obviously the one on the left is blocked halfway down. It's completely blocked halfway down, and you do not see the rest of the coronary artery at all. So this is the cause of his heart attack. There's a clot sitting right there in the middle of that coronary artery which is blocking the flow. Now in primary angioplasty, what we do is we take a very small wire. This wire has a soft, very fine tip, and because of that we are able to pass this wire through the blockage. The back of it is very firm, so this allows us to use this wire as a sort of a railroad, a support, and we can put many things over the wire, pass it through the clot, and because this wire is sitting in the middle of the blood vessel, we know that we can pass things down safely without injuring the wall of the blood vessel as we're trying to get things down. So once we have the wire down, we can either use a balloon to sort of move the blockage aside, or we can use a sucking equipment. We call it a thrombectomy catheter, which we pass through where the clot is, and we try and suck out, aspirate as much of the clot out as we can. So this is after we've done that. We put an aspiration catheter down and we sucked out the clot. Once we've done that, you can see that now there's blood flow coming down into the distal part of the right coronary artery. Okay, the flow is not normal, and that is because there's still a lot of clot sitting here in this part here, which is still affecting the blood flow, but at least we've restored some of the blood flow. So the next step would be to put a balloon at the point where it's tightest, to stretch that out even more, and then to put a stent there. So this is the final result after we've managed to put 2 stents here, one here and one here. Now you can see that the flow into the coronary artery is normal. So after we've restored the flow, the chest pain will have resolved, the ECG changes will have resolved. This patient would typically stay in the ICU for 1 day. The day after the heart attack, with medicine, his blood pressure has returned to normal. He doesn't have any more chest pain, doesn't have any shortness of breath. This is an echocardiogram, an ultrasound to look at his heart function. This is his left ventricle, and his left ventricle is normal in size, it's not enlarged. The walls are contracting very well. So this is normal left ventricular function, which is the optimal result that we want to aim for in somebody who's presented with an acute myocardial infarction. So why is it important to be able to differentiate between stable coronary disease and unstable coronary disease? Does it affect the management? This is a study that was published 3 years ago. It's called the Ischemia Trial. It stands for the International Study of Comparative Health Effectiveness with Medical and Invasive Approaches. Okay, and this is a very interesting trial. And what they did was they identified patients who had evidence of coronary ischemia. So the first thing they did was they tested people to find out, to identify patients who definitely had coronary ischemia, either by doing treadmill testing, or by doing dobutamine stress echo, or by doing nuclear perfusion scanning. Okay, so it's important that to be included in this study, you needed to have evidence of coronary ischemia. That means you have angina. You did not need to have a CT beforehand, you just needed to have evidence of ischemia. Once you were identified, then all these patients underwent CT coronary angiogram. Okay? And depending on the findings in the CT coronary angiogram, there was some exclusion criteria. The ones who made it through were then randomized, and they were divided into 2 groups. One group, the blue group, was treated with optimal medical therapy alone. So everybody is familiar with the optimal medical therapy for coronary disease, which is antiplatelets, beta blockers, ACE inhibitors, or ARBs, and a statin. That's the optimal medical therapy for stable coronary artery disease. So I don't really cover that in this topic. The other group, the red group, underwent coronary angiogram along with optimal medical therapy. And if at angiogram they felt that the coronary disease was significant, they were treated with angioplasty, or if it was severe, they were treated with coronary artery bypass grafting. Okay, so that is the premise of the study. You select a group of patients who definitely have coronary ischemia, you do a CT scan, and then you randomize them to either getting optimal medical therapy or getting angioplasty and stenting or bypass. And what they wanted to look at is, by comparing these two different treatment approaches, is there a difference in the rate of death, the rate of MI, the rate of hospitalization for unstable angina, heart failure, or cardiac arrest? And then we wanted to look at, was there a difference in the quality of life? So this is the inclusion, the eligibility criteria. So you needed to be over 21 years old. You needed to have evidence of at least moderate ischemia, which is, if you did a nuclear scan, it needs to show more than 10% of the left ventricle is undergoing ischemia. If you did dobutamine stress echo, you need to have at least 3 segments of the left ventricle that is showing akinetic changes consistent with ischemia. If you did cardiac MRI, is more than 12% of the myocardium has ischemia, or at least 3 segments of the left ventricle has wall motion abnormalities. Or if you did stress tests, which is the commonest one that we do in Malaysia, stress test, it has to have at least 1.5 millimeters of ST depression in 2 or more leads, or 2 millimeters of ST depression in 1 lead, at less than 7 metabolic equivalents. Okay, so that is, we are talking about a positive stress test at stage 2 or less. Okay, and then once you have evidence of ischemia, you go for the CT, and on the CT you must have evidence of at least more than 50% stenosis if you underwent nuclear perfusion or cardiac MRI or anything like that, or more than 70% stenosis if you only had evidence of angina on a stress test. So in Malaysia, it would be mostly positive stress tests, and CT showing more than 70% stenosis would be included in this study. Okay, they do make sure they want to exclude anybody who's like high risk, so they exclude anybody with severe heart failure, class 3 and class 4 heart failure. They exclude anybody who has very severe angina, no matter despite the optimal medical therapy. They exclude anybody with poor heart function, anybody with LV function less than 35%. They exclude anybody who recently had an acute cardiac event in the last 2 months. They exclude everybody who's had angioplasty or bypass within the last year. And they also exclude people with end-stage kidney disease. And importantly, they also exclude anybody on the CT who has more than 50% stenosis in the left main. So this looked at coronary disease in all the coronaries except in the left main. They did not feel that they could include that in this study. This is just some definitions about how they categorize myocardial infarction in this study. Not that important right now. And the endpoint definition is unstable angina is prolonged symptoms of angina at rest or accelerating, causing hospitalization, and with either new ECG changes or new angiographic evidence of worsening plaque. So that's unstable angina. Heart failure, more than 24-hour hospitalized for heart failure with symptoms and signs of heart failure, or the need to increase medicine to treat heart failure, and then cardiac arrest. So these are just the endpoint definitions. So they enrolled 8,000 patients. They had to exclude 3,000 patients, either because there wasn't enough evidence for ischemia on the initial screening, or the CT did not show any significant obstructive coronary disease. So these are false positive stress tests, false positive tests for ischemia, or they had evidence for left main disease. So about 3,000 were excluded. They were left with 5,179 patients. And these patients were then randomized, so about 2,500 in each arm. Okay, so that's 5,000 patients. It's a large population, and they were followed up for 3.3 years. So a good length of follow-up as well, 3 years. Now the baseline characteristics, just to show that there's no significant difference between either group. Majority were men, only about 23% were ladies. 70% had high blood pressure, 40% had diabetes. 20% had prior MI, but not within the last year. The LV function is normal on average in this group, 60%, and the blood pressure is well controlled, 130 systolic. The LDL is also reasonably well controlled, 86. This is milligrams per deciliter. 90% have angina. 30% have had worsening angina over the last 3 months. Because this was done not in Malaysia, a lot of the ischemia was detected using alternate methods to stress test. So they used nuclear perfusion, the most common one, and then dobutamine stress echo and cardiac MRI. And only about 25% had ischemia detected by stress test. And this group, you can see that 50% of this group would have severe angina by that criteria, and 34% had moderate ischemia. And when they looked at the CT, they found that about 24%, about 22 to 24% had single vessel disease, about 30% had double vessel disease, and almost half, between 44 to 47% had 3 vessel coronary disease. So this is not a low what we would have thought is a low risk group. These are patients with evidence of at least moderate ischemia, and 40% or more have 3 vessel disease. So at least 3 vessels have significant coronary disease. And then the distribution of the coronary disease, you can see that 87% would have left anterior descending, the LAD is involved. About half of that is in the proximal LAD, and then 70% have circumflex involvement and right coronary artery involvement. And this is to show, this graph shows that this group by the end of the study is very well medicated. The pink bar shows the average percentage of the patients who were on the medicine at the beginning of the study. The black bar shows the average percentage of the patients who were on the treatment at the end of the study. So you can see that 95% were on a statin from the beginning of the study, but by the end of the study, 66% were now on high intensity statin, which is either rosuvastatin 20 milligram or atorvastatin 40 milligram. And by the end of the study, 70% were either on ACE inhibitor or on ARB. And they also measured the LDL, so they managed to get a good response. 60% had an LDL of less than 70, which is 1.8 in our units. The blood pressure was controlled, systolic blood pressure less than 140 in 77% by the end of the study. 97% were on some form of antiplatelet, either aspirin or Plavix or something similar. 90% were no longer smoking by the end of the study, and 40% were considered to be at high level of optimal medical therapy by the end of the study. So they really treated these patients aggressively with medication. And this graph compares, the blue line is the optimal medical therapy group, the red line is the group that was treated with angiogram and angioplasty or bypass. And you can see that in terms of medication, there's no significant difference except in anti-angina medication. There's a big drop, a big reduction in the need for using anti-angina medication in the group that underwent angioplasty and stenting. The dual antiplatelet, that's just to be expected. Patients who undergo angioplasty and stenting will be on dual antiplatelets for at least 1 year, and you can see that the numbers kind of become equal after 1 year. So that's to be expected. This just to show how many of the participants actually underwent angioplasty in the invasive group. And you can see that even in the medical therapy group, there was about 30% of patients who eventually ended up having to undergo angioplasty as well, because they either had some primary event or they had failure of medical therapy and they had worsening angina that needed angioplasty, or they were not adherent to the medication and ended up having some event. For the patients in the invasive group who underwent angioplasty, the majority of them were treated with stenting. So 74% of the invasive group was treated with primary percutaneous coronary intervention, with a success rate of 93%, and the majority of these patients were treated with the newest type of stent, which is a drug-eluting stent. Okay. The remaining 26% had such severe disease that they needed to undergo bypass, and of which 93% used arterial grafts, including the left internal memory artery. So this is just to show that in the patient that underwent bypass, they underwent the best type of bypass. The outcome of either death or MI, again, there is no significant difference between these two groups. You might see that in the beginning, the red, there's a slight trend towards higher secondary events in the invasive group, but it balances out by the end, where there's a slightly higher incidence of death or MI in the conservative group. But the overall trajectory is very similar and there's no clinical significance. And if you look at just all-cause death, followed up to 5 years, there is no significant statistical treat these patients with stable, moderate ischemia, significant coronary disease on CT scan. There's no difference if you do angiogram or you just treat with medication. And for myocardial infarction, there's actually a slight increase in myocardial infarction in the conservative group. The type of heart attack that happens is slightly different between these two groups. When you undergo angioplasty or stenting, you run a small risk that during the procedure you can cause what we call a procedural MI, which is a type 4A or type 5 MI. So this is typically what happens in the invasive group versus a spontaneous MI that happens out in the general population, which is mostly what happens in the group that was treated conservatively. Is that important? I'll talk about it a little bit later on. In terms of hospitalization for unstable angina, there's no significant difference. In terms of hospitalization for heart failure, there's no significant difference. In terms of cardiac arrest, there's no significant difference. In terms of stroke prevention, there's no significant difference. So what can we conclude from this Ischemia trial? This was the largest trial ever done to compare whether or not doing angiogram and angioplasty in patients with stable coronary disease has any significant difference in outcome. From the study, an initial invasive strategy compared to a conservative strategy does not demonstrate any reduced risk for either death, MI, hospitalization for angina, heart failure, or cardiac arrest. And it does not reduce major secondary outcome of death or MI. So that's a lot that I just spoke about, so I'll just talk about it again just to summarize. This study is only applicable to stable coronary artery disease, so this is the group not unstable coronary disease. Nobody in this study has left main disease. The LV function is normal in this group, and nobody has LV function less than 35%. Nobody has severe heart failure, class 3 or class 4. So this study, the results of it is applicable to anybody who has evidence of 3 vessel coronary disease or less without left main stem. If you have somebody who fits this criteria, you have to understand that doing coronary angiogram and angioplasty does not reduce the risk of death. It does improve angina, which you can see in the graph that shows the medication, but it does not reduce the risk of death. Angioplasty seems to reduce the long-term risk of MI, because you can see that when you compare the invasive versus the conservative group, at the end of 5 years, the conservative group has a slightly increased incidence of MI, but angioplasty has an upfront risk of having a peri-procedural MI. Okay, is this important? It depends on who you talk to. If you talk to interventional cardiologists, the ones who are very, very aggressive about doing angioplasty, they would say that a peri-procedural MI is usually not as bad as a spontaneous MI. But that's just their opinion. They don't actually have any study to show that a peri-procedural MI is less severe than spontaneous MI. And until such a study is done, it's very hard to actually say that yes, an MI that occurs during an angiogram is not as bad as an MI that occurs spontaneously out in the general population. So I think the trick is to try and identify those who are at risk of MI in the conservative group and see if we can treat them earlier to prevent them from getting MI. But that is a completely different study. So how relevant is ischemia? One of the reasons I wanted to talk about this is when I talk to my patients, they have this, most of my patients have this misconception of stents in stable coronary disease. Okay, They seem to think that doing angioplasty, doing stents will save their lives, will be like the miracle thing that will change whether or not they die from a heart attack. So, patient questions. Will I die if I don't have an angiogram? If you have stable coronary disease? The answer is no. Will I die if I don't get stents in stable coronary disease? The answer is no. Will I get a heart attack if I don't get stents? The answer is, it's complicated. You might you have a small chance of getting a heart attack when you put the stents in, but if we put stents in and it went well, no problem. At the end of 5 years, you have a slightly lower risk of getting a heart attack at the end of 5 years. Why is it important? Well, if I can speak for other hospitals, but for us, if you come here, you undergo angiogram, you get one stent, the treatment cost is roughly around 24,000 ringgit. If you need 2 stents, it's 29,000 ringgit. If you need 3 stents, it's 34,000 ringgit, and so on. Like that's typically how it goes. If you treat, now remember, all these patients, regardless of whether or not you get stents, you still need to be on optimal medical therapy. So putting stents in doesn't mean you take less medicine apart from anti-anginals. You still need to take aspirin or equivalent. You still need to take beta blocker, ACE inhibitor, ARB, and a statin. So you don't save money on that. You do save money on not having to take anti-anginals. So is it worth it? This is the monthly cost of anti-anginals, commonly used anti-anginals, if you purchase them here. So the monthly cost of Vastarel is 162 ringgit, the monthly cost of Coronary is 282 ringgit, and the monthly cost of Imdior is 72 ringgit. So using these medications with optimal medical therapy, you can get an equivalent outcome to angioplasty and stenting for stable coronary disease, not unstable. Unstable, there's a lot of benefit from doing intervention. This is the other question. Can unstable coronary disease become stable coronary disease without doing intervention? Last year I had a 51-year-old man who came here. He's an Indonesian, he's working in the Indonesian consulate. He's an ex-smoker, he stopped about 10 years ago, he has type 2 diabetes. He came because he had a very prolonged episode of chest pain lasting for 4 hours with shortness of breath and excessive sweating. He went to his GP at 2 in the afternoon, who correctly diagnosed that this was acute coronary syndrome, gave him aspirin, sent him here. When he came here, he no longer had chest pain, and we did an ECG instead of blood test, and his troponin T is elevated. So this is unstable coronary disease, acute coronary syndrome. His ECG is surprisingly normal. There's no major ST changes, no major T wave changes. Now, he works as a driver, and because of this, he is unable to afford treatment with angiogram. Even though it's acute coronary syndrome, he should undergo angiogram, but he said he just doesn't have the money. He doesn't have the option to go to the government hospital because he's Indonesian, and he will be charged at the same price as we would. So what we did is we treated as we would for acute coronary syndrome without intervention, without doing angiogram. We gave him 3 days of Arixtra, the anticoagulant, along with optimal medical therapy, dual antiplatelets, statin, etc. His echo shows normal left ventricular function, so he's lucky. It's an uncomplicated non-ST elevation MI. And I discharged him on bisoprolol, rosuvastatin, metformin, Coplavix, which is dual antiplatelet, and Jardiance, which is a new diabetic medication, SGLT1 inhibitor, which has also been shown to have cardioprotective effects. So it's actually the 5th medicine you can add to the group now to reduce the risk of heart attack and stroke in the future. He continued to follow up with me very well for about 10 months. And then because of COVID and MCO, he missed his appointment after that. And he landed back in the emergency department after 13 months. And when I asked him, it turns out that he ran out of money. But it was, as you know, insurance, sometimes they will not cover if you only have it less than 2 years. And by this time his insurance was more than 2 years, and he was able to use his insurance. And this time we did an angiogram. Now this is just to show, remember this picture, this shows his echo the second time around. This is after his second heart attack, and that shows his left ventricle, and it's still showing normal left ventricle function. So please remember, when you're looking at the angiogram, please remember, this person has normal left ventricular function, no sign of significant damage. This is his angiogram. This is his left coronary artery. His left anterior descending is completely occluded, 100% occluded. His left ventricular function is normal. Left anterior descending is completely occluded. You can see the heavy calcification in the proximal left anterior descending. His left circumflex has severe disease. There's a 90% stenosis there, but it's still open. And this is his right coronary artery. His right coronary artery has a critical 99% stenosis just here. And then he has a 90% stenosis in the distal right as well. And he has severe disease in the smaller branches at the end here. Okay, but this is what's causing his heart attack this time. Okay, so I think that's amazing. This person has 3 vessel coronary disease. His left anterior descending is completely occluded. His circumflex is 90% narrowed, and he only after he has a 99% stenosis of his RCA did he suffer a second heart attack, and only after stopping his medication, which he's been taking for 11 months. So for almost certainly for 11 months his coronary disease was almost this bad, not quite as bad as this. I suspect the proximal right worsened after he stopped his medicine, but the medicine was able to keep him going without any symptoms for 11 months. Anyway, just to show again how severe that is hanging by just a thread there in the right coronary artery. And the left anterior descending is actually being supplied from the right coronary artery. So this is what it looks like after we fix it. We put a stent here, and we put a stent here, and now the blood flow is much better. There's still severe disease in the distal segments here, but it's too distal, I think, to do anything for. So he stayed in for 3 days. I sent him home on exactly the same medicine that he was on for the last 11 months. I didn't have to change anything. And he's been following up with me for 5 months now. And he has no angina, he has normal effort tolerance, and this is despite the LAD still 100% occluded and the circumflex has a 90% stenosis, which I think I want to fix later on, but again, insurance issues, so maybe next year. So in summary, coronary artery disease still remains the leading cause of death worldwide. The risk factors are being a man, age over 40, high blood pressure, diabetes, high cholesterol, and smoking. Acute coronary syndrome or unstable coronary disease is a medical emergency. It is associated with increased mortality, increased morbidity, and the treatment for acute coronary syndrome is still angioplasty. And coronary disease, this is a chronic medical condition, and it can be treated with medication. I'm not saying that none of them should get angioplasty. Or sometimes patients are told, Singapore and Australia and some countries in Europe, that there is a very small increased risk of myocarditis, which seems to happen mostly in men between the ages of 14 to 26, 28, something like that. The incidence is still very low, it's 0.001%. And as far as I'm aware, it has not affected the recommendation to use Pfizer vaccine in men. It has resulted in the advice for men who receive Pfizer vaccination who are in this age group to try and minimize strenuous physical activity for the first 2 weeks after vaccination. Okay. Again, it's very important to emphasize the incidence is very low, 0.001%, and but of course, any adverse event becomes hyperinflated, and I've actually lost count of the number of patients who have come to me in the last month who have recently been vaccinated and are having some chest pain and convinced there's something wrong. And so far, I haven't found anybody who's had evidence of myocarditis yet. Okay, normal ECG is normal echoes, just a lot of anxiety.
All right. Next one, doctor. In the future of medicine, do you see measuring omega-3 index taking over stress tests as a more accurate way to predict a cardiac event, doctor?
I think there will be increasingly better ways of predicting cardiac events. A stress test is actually an awful way of predicting cardiac events. The most useful stress test is a normal stress test, which gives you a good reassurance that you're unlikely to suffer a cardiac event for the first 4 months. Okay? A normal stress test doesn't even guarantee you a reduced likelihood of a cardiac event for longer than 4 months. That's really all it does. So stress test is actually a very poor substitute, but it's a cheap method for screening out coronary disease. That's why we use it. Okay, all the other methods are increasingly expensive. For the omega-3 index, I don't really have that much experience in it yet. I think once more data comes on it, then I'll be able to comment more on it.
Okay. All right. Next one, doctor. In primary prevention of coronary artery disease in high-risk group, does Plavix play a role? If so, how long does one take the medications?
Plavix currently fills the same role as aspirin. So traditionally, there have been 4 classes of medications that have been shown to reduce incidence of cardiovascular events in high-risk groups. So antiplatelets, aspirin, Plavix, Brilinta, beta blockers, ACE inhibitors. It's important to emphasize that ACE inhibitors are the ones that have been shown to have reduced mortality for MI. ARBs in all the studies did not show reduced mortality for MI, but typically they're grouped together because they work similarly. ARBs did show reduced mortality in heart failure, but no study showed reduced mortality for MI. And then statins. So traditionally, these 4, antiplatelets, beta blockers, ACE inhibitors, and statins are the ones that show a reduction in cardiovascular events in high-risk groups. Okay, you can now add SGLT1 inhibitors, which are Jardiance, Forxiga. What's the new one? Steglatro. These are all SGLT1 inhibitors, and in studies they've been shown to reduce the risk of heart attack and stroke as well. So that's now 5. So when you ask me the role of Plavix, it currently occupies the same role as aspirin. Whether it will replace aspirin in the future is a question, and it is possible. There's more and more studies that seem to suggest that Plavix has more benefits over aspirin with regards to both the reducing cardiac events as well as lower side effects, lower adverse side effects.
Okay, next one, doctor. In Wolff Parkinson-White syndrome, if any angina or unstable angina occur, what mode of treatment of preference in the first golden hour, doctor?
Okay, so Wolff Parkinson-White is electrical abnormality where there's an accessory pathway inside the heart. It does not affect the treatment at all for acute coronary syndrome. It would still be primary angioplasty and antiplatelets and everything as I laid out earlier. The presence of the Wolff Parkinson walk will not affect how you treat this at all. It won't affect it at all.
All right. Next one. Do we need to give 2 antiplatelet drugs, doctor?
It depends on the situation. If it's an acute coronary syndrome, yes, you should give dual antiplatelet therapy. Now, this is all based on studies that were done in the 1990s, from when we first only had aspirin, and then done in the 1980s when we first had aspirin, and then we finally had thienopyridines, of which ticlopidine was the first one, and then we had clopidogrel, and now we have Brilinta, and then we have prasugrel. And in those initial studies, they used dual antiplatelet therapy. Whether that might change in the future and aspirin no longer plays a role, that's being debated right now. But for now, yes, we use dual antiplatelet therapy for acute coronary syndrome. For stable coronary artery disease, it's still mostly single antiplatelet therapy, and you have a choice. You can either use aspirin or you can use something else like clopidogrel if you want to. I'm increasingly using clopidogrel for stable coronary artery disease, mainly because I want to avoid the gastric effects of aspirin.
Okay, all right. Next one, doctor. How to stabilize the coronary plaque? Any possibility to shrink the size and hence stabilize it? What are the strategies?
All right. So the main medicine that helps to stabilize coronary plaque, unstable coronary plaque, is statin. And this has been theorized for a very long time. From the very early statin studies, people noted that the reduction in cardiac events was excessive compared to the reduction in LDL that they found. So the statins will reduce LDL by this much, but they will reduce the incidence of cardiac events by this much. And they couldn't really explain why there was a bigger reduction in cardiac events compared to the reduction in LDL. And the prevailing theory is that the statin helps to stabilize the surface of the cholesterol plaque and reduces the likelihood that it ruptures. So I would say that would be the main thing, would be to use statin to stabilize coronary artery plaques. Now, coronary artery plaques are not a single entity. There's different types of coronary plaques. There are young plaques. Young plaques are typically very lipid-rich with a very thin crust. These are the ones that are theorized to be the most unstable, most easily broken open. Then, as they get, as they become more established, they start to become thicker, and then they become calcified. And probably the calcified plaques are probably the ones that are least likely to rupture. Not impossible, but least likely to rupture. You can identify these plaques if you put an ultrasound probe into the coronary artery. You can actually look at the type of plaques inside, and there are some cardiologists who are pushing for this. They say that you should do plaque analysis to identify which plaques are at higher risk for rupturing, and therefore maybe these plaques should be treated with angioplasty and stenting. The data is, I think, still a bit young to make a recommendation on that, but that is maybe one possibility. As for making plaques smaller, there have been some studies, again involving statins, very high doses, looking at cholesterol plaques inside the neck, the carotid arteries, which show some regression of plaque in the carotid with high intensity statin treated for more than a year. But the regression is very small. It's measured in nanometers, so not as significant, not in millimeters. And until now, there hasn't been any other medication that can regress plaque yet. Okay, I'm sure somebody's working on some potential drug that can promote, for example, promote the delivery, the activity of HDL to move cholesterol from the from the blood vessel moving back to the liver, but until now there's none that is on the market.
Okay, all right. Next one, doctor. A patient in early 40 with hypertension, no other risk factor, started on aspirin due to clinically suspected stable angina. Stress test turns out negative. Do we stop the aspirin in this case?
Hard question, tricky question. Can you say that again?
Okay. A patient in early 40 with hypertension, no other risk factor, started on aspirin due to clinically suspected stable angina. Stress test turns out negative. Do we stop the aspirin in this case?
You have to take it on a per patient basis. If the aspirin is not causing any issues, it's not causing any gastric symptoms, the hemoglobin is stable, there hasn't been any major bleeding of events, there is still benefit for taking aspirin in this patient. It lowers the risk of stroke, it lowers the risk of MI. The benefit is not big. The benefit is somewhere between 5 to 10% only in the relative risk reduction. So we're talking about small benefit. But there is still a benefit, and if the patient is tolerating the medicine without any problems, I think I would continue it.
Okay, all right. Next one, doctor. Is the patient would benefit from CABG, doctor?
What's the question?
Sorry, is the patient would benefit from CABG?
Who is the patient?
This Dr. Razi only give us this question, doctor.
Is the patient?
Is the patient would benefit from CABG? Yeah.
Okay, let me see.
Yeah, I think maybe.
So, which patients would benefit from CABG? As opposed to angioplasty and stenting. So, which like if a patient has coronary artery disease, confirmed on angiogram, and is significant, which patients would benefit from coronary artery bypass versus angioplasty and stenting? So this is a very tricky question with debates on both sides. Cardiologists always want to say angioplasty is better, cardiac surgeons want to say bypass is better, but it actually depends on how complex the coronary disease is. So there has been quite a few studies now done, started in the 90s, starting with the SYNTAX study. And the SYNTAX study took patients with 3-vessel coronary disease which had been judged. The experts had looked at the angiogram and decided that this can be fixed either with angioplasty or with bypass, suitable for both. Okay. And they randomized these patients into 2 groups. One group got angioplasty and stenting, one group got bypass. And this study was done by the very top cardiologists. It was designed by the top cardiologists and the top cardiac surgeons, and therefore the angioplasty was done to the best of their ability, and the bypass was done to the best of their ability. And while they were randomizing these patients, they also developed a scoring system to sort of grade the severity, the complexity of the coronary disease. And it turns out the more complex the coronary disease, the bigger the benefit for bypass. And the SYNTAX, there's a SYNTAX score now. So I can look at an angiogram and I can calculate the SYNTAX score. If your SYNTAX score is above 33, you benefit from bypass. If your SYNTAX score is below 33, then the benefit is almost the same. The lower your SYNTAX score, the more benefit from angioplasty. So very simple coronary disease, more benefit from angioplasty, less risk of complications. The higher the SYNTAX score, the more benefit from bypass. If you have diabetes, then the cutoff becomes around 23. SYNTAX score 23 or above with diabetes, more benefit from bypass.
Okay, so we come to the final one, doctor, the last question. Dr. Ashraf, do we still have to give aspirin and statin for unstable angina patients?
Oh, definitely. Definitely.
All right. Okay, I think that was the last question we have for today. Dr. Ashraf, do you have any last remarks for for our viewers today, doctor?
Thank you for watching at this time. It's been a pleasure, and have a nice night.
All right, thank you once again, Dr. Ashraf. To all doctors, please don't forget to scan the QR code at the end of this live by using your MMA doctor phone application to get your CPD point now. If you have any difficulties, please click on the link for doctors only in the comment section to confirm your attendance manually. And to all the Gleneagles Hospital Kota Kinabalu staff who are watching this now, please don't forget to click on the link which is specified for GHKK staff only in the comment section for your training purpose. Please make sure you click the correct link for your attendance. And also, we have another online CME session with our resident pulmonologist and physician, Dr. Arfian Ibrahim, on the topic of diagnosing COPD in primary care and the challenges on 14th of October at 6 p.m. Let me know if you are interested. We will share the link with you. We have come to the end of our online CME today. Thank you very much for watching, and see you next time.